A 55-year-old woman presented to her primary care physician with complaints of diffuse bone pain and increasing difficulty walking over the past several months. She described the pain as dull and aching, particularly in her hips and lower back. Additionally, she reported experiencing muscle weakness, particularly in her thighs, which made it challenging to climb stairs and rise from a seated position. She had no significant history of trauma, fractures, or recent changes in her physical activity level. Her medical history included a recent diagnosis of celiac disease, and she had been trying to adhere to a gluten-free diet. However, she noted that her symptoms had not significantly improved since the diagnosis. Her physical examination revealed tenderness over her long bones and proximal muscle weakness. No neurological deficits were observed. The physician ordered a series of blood tests, including calcium, phosphate, and alkaline phosphatase levels, which were within normal limits. The patient was diagnosed with nonspecific musculoskeletal pain and prescribed nonsteroidal anti-inflammatory drugs, or NSAIDs, for pain relief. She was advised to continue with her gluten-free diet and return for follow-up in 3 months. Diagnostic error. Explanation. The diagnostic error in this case was the failure to consider osteomalacia as a potential cause of the patient's symptoms, especially given her recent diagnosis of celiac disease, which is associated with malabsorption and can lead to vitamin D deficiency. The combination of bone pain, proximal muscle weakness, and the context of a malabsorptive condition should have prompted an investigation into vitamin D status. The appropriate diagnostic test in this scenario would have been to measure the 25-hydroxyvitamin D level, which, if found to be low, would indicate vitamin D deficiency as a contributing factor to her symptoms. Osteomalacia, resulting from insufficient vitamin D, can lead to softening of the bones and characteristic radiographic findings such as Looser's zones, which are areas of incomplete fractures that can be mistaken for fractures. By not assessing for vitamin D deficiency, the physician potentially missed the correct diagnosis, leading to inadequate treatment. Proper management would include supplementation with oral 1,25-dihydroxyvitamin D and addressing the underlying malabsorption issue. Without appropriate treatment, the patient could continue to suffer from pain and progressive bone weakness, increasing the risk of fractures and other complications.